moderator today. So our first speaker is Dr. Rabia Sharif Bhatti, and she is going to say a few words about endothelial changes in keratoconus patients. Dr. Rabia, please.
At Al-Shifa Trust Eye Hospital. So we conducted a study at our setup that corneal endothelial cells, they undergo some changes and they are different in different stages. So we conducted a study to highlight the change. As we know that keratoconus is a global disease, with higher prevalence in Southeast Asia. It is a potentially blinding condition if it is not timely diagnosed and treated. Milder degree of disease can be treated with spectacles, rigid lenses, intacts, or cross-linkaging. However, advanced disease needs a corneal transplant. So as we know that last resort of treatment is a corneal transplant, penetrating keratoplasty carries a higher risk of immune reaction compared to a DALP graft. But DALP needs a healthy donor, a host endothelium for the survival of the graft. Literature has highlighted the variability of endothelial cells in correlation to the stage of keratoconus. The endothelial cells can be decreased or static, however they might not be functioning as a healthy cornea. So we conducted a study to assess the changes of cell count and the morphology by using the specular microscope. The purpose of the study was to evaluate the changes in corneal endothelial cell morphology, the cell count in keratoconus patient in correlation with the stage of keratoconus. It was a cross-sectional study that included a total of 564 eyes of 376 keratoconus patients. The duration of study was from the April 21 to December 21, and it was conducted at our Cornea and Refractive Department of Al-Shifa Trust Eye Hospital. The patients were classified according to the Amsler-Krumix classification into 4 stages. Inclusion criteria was all the patients with unilateral or bilateral keratoconus. They were included, and later on they were classified into the stages. A total of 130 eyes were in stage 1, 206 patients in stage 2, 124 in stage 3, and 104 in stage 4 were included. The exclusion criteria was a patient with age of more than 35 years, as the patient after this age they are undergoing a age-related decline in the endothelial cell count. The patient with a history of contact lens were also excluded because they also have some endothelial changes, previous ocular surgeries that might affect the cell count, acute eye drops, previous cross-linkaging, or formed frustrated keratoconus. The patient underwent a complete ophthalmological examination that included their corrected and uncorrected visual acuity, examination by the slit lamp, then their topography and thickness data was collected from the Scheimpflug camera G4. Corneal endothelial cell data was measured using the non-contact specular microscope. We have Tommy EM4000 at our setup. Outcome measures of the specular microscopy were evaluated in terms of cell density, polymagnetism, and pleomorphism. The cell density of the analyzed cells as number of cells per 1 millimeter. Polymagnetism was a difference in size and distribution of the cell dimension. Cell surface area from 0 to 100 to more than 900 micrometer per cell, micrometer square were included in the study, and pleomorphism was also assessed. The data was analyzed using the SPSS version 22. The patients were described in terms of mean, SD, range of the normally distributed data, and median. The categorical data was described as frequency and percentage of the total. For more than 2 groups comparison, one-way analysis or ANOVA was used. So 57.8% of the patients were male and 42.2% patients were females. The mean age was 19.91. The comparison was done as P1, 2, 3, 4, 5, and 6. This was the intergroup comparison that we did. So what we saw was that in the stage 4 of the keratoconus patient, there was a generalized decrease in endothelial cell density compared to stage 1 patients. And then coming to the cell surface area, they were analyzed, and we assessed the endothelial cell surface changes in the 4 stages of keratoconus. And what we saw was that in the advanced stage of the disease, the cells with the higher cell surface area, that is cells with a cell surface area of more than 400 and 500 were started to increase, and the cells with a normal cell surface area, they were decreasing in number compared to stage 1. Later on, coming to the cell morphological changes, as we can see that in the stage 1, most of the patients have a hexagonal morphology, and very little number of patients they have decagonal or trigonal morphology. But as we move toward the stage 4, we can see that the patients with a nanogonal or a decagonal morphology and also the tetragonal and pentagonal morphology is increasing. So, as we know that keratoconus affect both the interior and posterior corneal surfaces, the changes in corneal endothelial cell number and morphology are more pronounced in the advanced stages of the disease. Evaluation of the corneal endothelium is therefore important, since theoretically these cells may be damaged. Whenever the endothelial cells undergo a damage, there is a healing process of cellular enlargement or fission that result in the change in the cell morphology and their cell surface area. Pleomorphism means a change in the cell morphology. A hexagon has the greatest cell surface area in relation to its perimeter. However, it is the most efficient shape for covering the given area. In a normal cornea, 60 to 65% of the cells are hexagons. They decreased to the normal distribution of 60% of six-sided cell to a lesser percentage can be the result of stress to the endothelial cells. We compared our study to the number of other studies that are conducted internationally and found that Ahmed El-Mesri, Yukon et al., Niederer et al., Timusin and Eloga and Goebbels, they have also conducted a similar study. Most of the studies showed similar result to our study, but Niederer and Timusin, they found that there is no significant change in endothelial cell surface and their density in advanced stages of keratoconus. So from this study, we concluded that qualitative and quantitative structural changes are seen in keratoconus. These changes are very mild to moderate in the stage 1 and stage 2. However, they are quite significant in stage 3 and 4. So specular microscopy is an important investigation on the follow-up patients of keratoconus. This study can recommend that penetrating keratoplasty may be a superior option compared to DALC in the management of stage 3 or above keratoconus, as the endothelial cell change will interfere with the stability of the DALC graft. These are the references, and thank you.
It was an excellent presentation. I think with the permission of the chairman, the question and answer session should be at the end. Sir, question and answer session at the end, I believe that will be. So our next presenter is Mahfouz Hussain, and the topic is diagnosis of corneal ulcers.
कैसे खुलेगी ठीक है हो गया राइट क्लिक से Bismillahirrahmanirrahim. I'm going to present something new, something we are trying in Peshawar, and that's the molecular diagnosis of corneal ulcer. I'll just quickly go through the details why we thought of that. That's me. No financial disclosure. Thanks to Peplo for guiding me for this study and for this concept. Now, what we are doing is, I've divided the talk into 4 or 5 sessions mainly. Why in ophthalmology we need early diagnosis, traditional microbiology and its disadvantages, then the alternatives, and then what's the molecular diagnostics and how it works and what is the procedure. It's much more simpler than what would you think at this stage. Now, 2 things we come across that need urgent attention by an ophthalmologist. One is the corneal ulcer, and second is in the endophthalmitis. In these 2 things, if you don't have the early diagnosis, then the results are devastating, particularly in endophthalmitis. Me, being a corneal surgeon and a vitreoretinal surgeon, I get these both of these regularly. In endophthalmitis, if I don't treat it precisely, the eye goes, and in the corneal ulcer, if we don't do the precise diagnosis and specific treatment, then it can perforate and leads to many complications. So we need to diagnose these two things very early so that we can start the appropriate treatment. In addition to what we need, people in other doctors in the hospital, people treating the septic shock, infectious diseases, gynae ops, neurology people. In the neurology, there's a patient with meningitis. You don't know whether it is bacterial, fungal, or viral, so they need the diagnosis as well. So it's not only the ophthalmologists, it's the other specialties who need the early diagnosis as well. So we are not working for ourselves, we are working for the whole profession. So traditional microbiology, this is traditional microbiology, started in the previous century, and the time-tested technique, and still valuable and still working, and we still use it. Problem, what is the problem? Me being an ophthalmologist, I've got a patient of keratitis, which is the corneal ulcer, and control. Time for the culture is 48 hours, but that time endophthalmitis eye is gone. Same is the retinitis, meningitis, all those things. So it takes minimum 48 hours. You can do this microscopy and just guess what it is, but the actual culture report comes late. What we need is as soon as possible, usually on the same day and usually in the same session. So how we can achieve that? So these are the problems. It minimum takes 2 days. Some organisms cannot be detected. Only possible for organisms with known growth patterns. So if the microbiologists don't know the pattern of the growth, he cannot recognize. So new pathogens cannot be recognized. Poor discrimination with the microbes with common phenotypic features. Some of them are very common features, so you cannot distinguish between the two. Detection of the slow growing organisms are, you just cannot detect. If fungus takes, I'm in Pakistan, I'm not aware of any lab who can work on the fungi. So fungus is just a guesswork. You cannot diagnose. We don't have a class 3 laboratory in KPK, and I'm sure there's none in rest of Pakistan as well. Fungal growth only in few laboratories, not in Pakistan perhaps. Viral diagnosis is difficult. We don't actually diagnose the viral, we just diagnose them by symptoms and sign. Chlamydia is not diagnosed in routine laboratories. So, what are the alternatives? This is the traditional one, and this is the alternative, and I'll explain what is the alternatives. This is the molecular diagnostics. What you do, we have got a DNA, and the DNA, if you collect it, is called genome. You have got the RNA in the cell, that's called transcriptome, and then you have got the protein, so proteome, and the metabolites, metabolome. Genomics is a use of combination of recombinant DNA sequencing methods and bioinformations to sequence. It's basically you're working on the DNA, you sequence it, you assemble it, and you analyze it. So what you have to do is you have to extract the DNA. Proteinomics is the study of the whole proteins. All these proteins are formed by the RNA. So this is actually the blueprint of the RNA working. Now, molecular diagnosis is if you combine the genomics and proteinomics, that's molecular diagnosis. It would look very fancy, but it's much more simpler than what you think at the moment. Now, how we do the DNA sequencing, how we study the DNA. There are many methods. That's one of my friend, Italian, he's working on this. So I collaborated with him and I started sending him samples. What happens, they have got the lab, so DNA lab. In that lab, they have got DNAs of all the organisms, almost all the organisms, bacteria, fungus, virus, everything. What they do, they take the DNA from the ulcer and they match it. Whichever it matches, it's like a library. So they've got the sample and they've got the library. Whichever matches, they know that this is the organism. What was the problem? I wanted to diagnose patients early. Sending sample by DHL, and that takes about 2 to 3 days, sometimes 4 to 5 days. So that thing that we wanted to achieve, the early diagnosis, that was not possible. Then I tried to copy that system, but it was so expensive. that we couldn't afford it. In the government sectors, we have to convince the secretaries and all those which takes years, and we couldn't do it on our own because it was very, very expensive. So that project couldn't go ahead. Then another technique is melt it off. In melt it off, what they do is they take the DNA and they blast it. By blasting it, what they do is, like if there's a little blast here, this thing will be thrown away, further away as compared to this thing, because this is heavy. So the blast will throw it like, say, 10 feet. This will go up to 20 feet. So they know the patterns that this bacteria can fly that much, this bacteria can fly that much. So what they do is, they take the DNA from the sample and the melt it off technique blasts it. The Staphylococcus will move that much, Strepto will move that much, fungi will move that much. So by distance, they know that how much distance the organism has traveled. They know by their knowledge that it's that particular type of virus or bacteria or fungus. So both these techniques, melt it off and DNA sequencing, they are the same things. They are comparing it with their own library. So this melt it off is very, very expensive. Very few hospitals have that, and again, we couldn't afford it. So we had to go to something simple. So what is molecular diagnosis? What we are trying to start? Key is the DNA. So you have to extract the DNA. Not very difficult. What you do is, you have to remember this slide. Every organisms contain a unique, specific DNA sequence. Like a humans, every human, our DNA will be different, but there will be one particular sequence that is same in all the humans. Same as the monkeys. One sequence is common for all the monkeys. That's how, when you get the fossils, you take the DNA and you look for that species specific DNA, and you know that this fossil belongs to that group or that human or animal or whatever it is. That's how the DNA works. And the molecular diagnostics makes the species specific DNA visible. So how you do is, simple PCR test. We will use this molecular diagnostic technique. What happens? The DNA, 3 DNAs are at the top. 3 DNAs are, now these are the 3 DNAs. These are the 3 DNAs. We don't know which DNA it is. Now this is the DNA of Staphylococcus. This is DNA sequence of Streptococcus, Pneumococcus, Aspergillus, Fusarium, and Candida. What you look for is, now TCC80 is common to all the Staphylococci. Then the to all the bacteria. Then the Staphylococcus is TCC80G, Streptococcus is TCC80A, so then it changes. But one sequence is common to all the bacteria. Same is one sequence is common to all the fungi. So we know that this is the species specific DNA sequence of bacteria, and this is the species specific DNA sequence of fungi. So what we do is, we take the opposite of it, because when you've got the opposite, then you can lock and key mechanism. So what you do is, this is the is with the A and C with G. That's the basic that's the basic DNA thing. So what you do is, you design a primer that is exactly opposite to TCC80. So that is T for A, C with the G, C with the G, A with the T, and T with the A. So you design a sequence, or we call it primer. So you design a primer which is exactly opposite to the species specific DNA of the bacteria, and you design another one for the species specific DNA of the fungi. So now we have got 2 primers, primer for the bacteria and primer for the fungi. So what you do is, you've got a patient now, this is the ulcer, you take the sample from that ulcer with the routine methods, whatever you do, and that's your sample. You add it in the PCR tube, and you have added the 2 primers with that. Now, whichever the primer attaches to that sample, the patient has got that particular type of organism. So at the moment, we don't know which bacteria it is, but if instead of 2 primers, you have got designed 20 primers, like instead of having a bacteria and fungus primer, if you design Staphylococcus, Streptococcus, Pneumococcus, Aspergillus, Fusarium, so we have designed 11 primers. So if you add the 11 primers, whichever primer attaches to it, it will be that organism. So in the next example, we have designed the primer for the bacteria Pneumococcus, Streptococcus, and so we know the patient from the previous slide, we know that it is bacteria. So then you add 3 primers, Pneumococcus, Streptococcus, and this one attaches, so you know that the sample is Streptococcus. So that one problem with that is you cannot actually do the sensitivity part. In the normal bacteriology, you can do the culture and sensitivity. But what you can do is you have got the similar medicines, broad spectrum antibiotics, so you don't actually need that. So what you can do is you can treat the sample with this technique and send it to the lab for the culture and sensitivity. By the time the culture and sensitivity will come, at least you would have done the precise treatment. What is the procedure? Simple PCR, take the sample, add the primers, add the nucleotides, and the ZAG and the mixed buffer and the PCR tube, and run it for 2 hours. And that's how the PCR, that's just a routine thing. I don't want to go into that detail. Advantages of that: speed, rapid identification, high sensitivity, high specificity, and in-house. You cannot use the companies do not work for you, so you have to design these primers in-house. It looks very expensive. It hardly costs 100 rupees per primer per patient. So if you add 13 primers, it's going to cost 1300 rupees for the whole set. So it's not very expensive. You only need to know the technique. So it's not expensive. You need very well trained technicians for that, coordination between the doctor and the technician, so all those things. The future belongs to molecular diagnosis, and we are going to see it more and more in the future. Thank you very much. That's one of my papers on the molecular genetics, and the other one is published last month. I have that in here. Thank you very much. They are available. We are doing it. We have designed the primer for the bacteria, and we have designed it for the Staphylococcus aureus and Pneumococcus. We are molecular lab.
No, sir. You are talking about your setup.
Ji.
Which setup?
I am doing it with the Agriculture University. So there's a lecturer in Agriculture University who works on genetics. So I'm working in collaboration with him. Actually, all the work that I'm going to tell you and all the other papers that I'm doing is all done in Agriculture University, not in any medical part. Because when you're working with the genomes and the DNA, you don't need a medical laboratory. You need a laboratory who can play with the DNA. So all I'm doing it in the Agriculture University Peshawar. So I'm collaborating with them, and we're designing with their help.
Will they be available to us for clinical use?
It will be when the whole thing is designed and patented and everything. Then it will be, but it's going to take time.
I must say, and Dr. Mahfouz has really enlightened me. Before that, I thought that primer was only before the paint. But now I know that it's so our next presenter is Professor Mukeed from Al Shifa Trust High Hospital.
प्रेजेंटेशन किधर पड़ी है यार? बिस्मिल्लाहिर्रहमानिर्रहीम। Thank you very much. Assalamu alaikum, ladies and gentlemen. I am going to talk a little bit about my experience with deep anterior lamellar keratoplasty. DALC has very effectively taken over as an alternative to PKP due to its inherited advantages of preservation of endothelium, descemet membrane, early stabilization, and low risk of complications, and lesser chances of graft rejection, and probably better VL outcome. Once consider disadvantages like long learning curve, tedious procedure, and high rate of descemet membrane perforation are no more considered limitation due to increased experience of the surgeons and with the development of this Dr. Anwar's big bubble technique. DALC is usually done manually and facilitated by air viscoelastics, and big bubble technique using air is most popular. There is need and always was need to develop a simple procedure to using simple instruments in our setup. After Dr. Anwar's big bubble technique, this DALC has been popularized worldwide, but we have not opted for the procedure because of opacity of tissue and training constraints and expensive instruments. So we started it with very simple procedures and wanted to evaluate our results and provide some tips to those who want to change from conventional PKP to DALC. So technique is very simple, starting with marking, trephining with the ordinarily available long handheld trephine, and deepening, pocketing with the routinely available instruments present in all cataract and keratoplasty sets. So this is a brief video. Before going on to the results, usually videos do not run in these systems. चलनी चाहिए यार सारी फाइल बीच कोई चला दे चल ये चल पड़ी है ठीक है. So after centration, definition with the routine long handheld trephine, tunnel making with iris repositor, and then ordinary cannula is used to make big bubble. This is a type 1 big bubble, and all the instruments, there is no specifically designed instrument used in all these procedures. Sometimes viscoelastic can be used to facilitate the separation between the stroma and descemet membrane. In my initial cases, I did not use to perforate or enter into the anterior chamber. Sometimes walking on a tight rope is probably easier than walking on a loose platform. But if somebody feels difficulty and there is more chances of descemet and perforation, always we can do anterior center paracentesis. And next. Chalo. This is another simple centration. 7.75 trephine was used. Again, deepening of the trephine wound with the crescent and L1 number blade. Iris repositor for tunnel making. Normal cannula, and rest of the procedure is the same. Again the same procedure. In previous cases, type 1b bubble was formed. Here probably it will be the mixed one. Yeah. The message is that we need not to wait for expensive instruments with specific instruments. It can be started. It can be done with the basic instruments. Basically, the technique and the procedure is more or less the same worldwide, with very little variation in technique and instruments. Next. Okay, go on to the. We have few speakers, so we are not short of time. I hope. Next. Okay, the objective was to determine 1-year visual and refractive outcome of TAL in patients with advanced keratoconus using this expensively readily available instruments. Study was an observational study done at Al Shifa Trust Eye Hospital, Rawalpindi, starting from November 2016 to March 2021. In collagen clarity, a best corrected visual acuity was less than 0.6 log mark, rigid gas permeable RGP intolerance, and of course PS was not suitable for cross linking, and intracorneal it was not also suitable for ICRS. Acute ID eye drops, previously ocular surgeries, and of course unsuccessful DAL which need to be converted were not included in the study. 64% were male and 36% females with an average age of 18 years, 16 months follow-up. I used most trephination diameter between 7.50 and 8.25 millimeter. So there were 120 intended DALC, and we completed DALC in 102 cases, and rest of the cases are converted. One successful big bubble was made in 68% of the cases, and type 1 or mixed bubble was made in rest of the cases. There was 1.7% cases we have microperforation, and in 15% of the cases we have macroperforation during surgery. Microperforation was considered one in which we can maintain AC with the air and balance BSS, and in cases where we could not maintain AC with air or BSS, we labeled it as macroperforation and converted to conventional PKP. Bus corrected visual acuity pre-op was 1.11, and after 12 months follow-up it improved to 0.46 log mark. K-max from 62 pre-operatively reduced to 49 at 1 year follow-up. Spherical equivalent minus 1.60 at the end of study minus 5.65. Similarly, topographic astigmatism pre-operative 4.63 to around 3. Endothelial cell count density, which was 2726 pre-operatively, and post-operative 6029. This endothelial count here, this Dr. Rabia has presented now just in grade 3 and 4 cases, there is change in the endothelium. Though this is a controversial topic, in previous studies, though there are some morphological changes, but still it is a debatable area. But here, in our study, endothelial count was not much significantly affected after that. central corneal thickness on an average it was around 350, and after surgery of course it increased to 530. So we do not have any significant complication with the procedures. This graft rejection is rare with the adults. We have our share, 2 patients which were treated successfully, and graft was junction opacification in 28 patients. Better instrumentation, better trephination can of course reduce this further, and there was mild interface of opacification in 7 patient cases. None of them affected visual acuity because in all of the cases there was complete DM bearing. So we can say that DALK is a valuable surgical technique in to PKP in advanced keratoconus, and readily available inexpensive instruments can be used to perform DALK with favorable results. DM bearing can be achieved with both slashing the type 1 big bubble or by manual layer by layer dissection with comparable visual outcome. Type 1 big bubble formation and surgeon experience can reduce the risk of intraoperative complications and conversion rate to PKP. Thank you very much. Journal of College of Physician Surgeons.
Very informative, Dr. Sam. Excellent presentation. I'm sure that everybody benefited. Now the house is open for question and answer session. Any questions?
Would like Dr. Mahfouz to further elaborate facility available at hand everywhere, because it's very simple and definitely you have.
ये हर दफा एक नया इनोवेटिव जो है ना सिस्टम लेकर आ जाते हैं, हमें कंफ्यूज कर.
No, the important aspect is that this is
ये तो 1 साल पहले आपने प्रेजेंट किया था, आप तो पुराना हो गया था.
11 तक पहुंच गए, हमें नहीं देंगे.
sir, but remain committed with the charges that it costs 100 rupee per primer and बाद में जब चीज बन जाती है तो becomes expensive.
समझता ही होगी कि आपको सच्ची बात बताता हूँ कि जिनके साथ मिलकर फिर उनकी नीयत खराब हो गई. तो वो आप कहते हैं कि इसके ऊपर तो प्रॉफिट होगा, इसको पेटेंट कराते हैं, इसको हम ये कराते हैं, मैं उसको कहता हूँ इसको बनाते हैं और इसको जो इस्तेमाल करे वो करेगा. तो वो कहते हैं इसको पेटेंट करवाते हैं दैट्स द प्रॉब्लम विद द मूवमेंट एक्चुअली दैट्स नॉट समथिंग. तो लेकिन ये हो जाएगा. इट्स वेरी इजी. आपने सिर्फ लेबोरेटरी में बैठ के कंप्यूटर में बैठ के प्राइमर डिज़ाइन करना है. प्राइमर डिज़ाइन करने वाली कंपनी अमेरिका में और यूरोप में, आप उनको सीक्वेंस भिजवाएं, वो आपको पूरा डब्बा भिजवा देते हैं प्राइमर. उसमें से आप एक चम्मच निकाल के उसमें डालते हैं.
Definitely, because the traditional conventional method of microbiology, they are useless, I think, because the time patient comes to us, he has already been on a lot of antibiotics.
कोई कल्चर में कुछ
अब ये सारे चाहते हैं कि हम सारे जो है ना इस इनोवेटिव है, तो ये थोड़ा वर्कशॉप हो आपके वहाँ और हम आ जाएंगे और थोड़ा खाना वाना
हमने एक पेपर हमने पब्लिश किया, लेकिन वो मैं डायबिटिक रेटिनोपैथी पे कर रहा हूँ. वो मैंने प्रेजेंट किया था पेशावर में. उसमें हमने ये किया कि हमने डायबिटिक्स के सैंपल लिए, उसमें हमने 3 जीन्स देखे. हमें ये पता है कि डायबिटिक जो है ना वो उनमें कुछ जेनेटिक डिस्पोजिशन होती है. हमने एक जीन आइडेंटिफाई की है कि इफ द पेशेंट हैज गॉट दैट जीन, तो उस जीन वाले पेशेंट में प्रोलिफरेटिव डायबिटिक रेटिनोपैथी के चांसेस जो थे वो 90% थे. सो व्हाट वी आर प्रपोजिंग इज कि अगर आपके पास पेशेंट में डायबिटिक आपको फिजिशियन ने डायग्नोज किया है, तो आप उसका डीएनए एनालिसिस करें, जेनेटिक एनालिसिस करें. अगर उसमें वो दैट पर्टिकुलर जीन है तो उसको फिर फॉलो अप करें विगोसली. और अगर उसमें वो पर्टिकुलर जीन नहीं है तो फिर देखा हम ना 1000 पेशेंट को कहते हैं कि आप 3 महीने बाद आना. पेशेंट का ये ख्याल होता है कि डॉक्टर अपनी फीस के लिए बदला है. I mean that's what the reality is. आप उसको कहते हैं 6 महीने के बाद वो कहते हैं फीस नहीं है. आप 6 महीने बाद आप उसको देखते हैं और आप उसको कहते हैं कि तुम्हारी आँख बिल्कुल ठीक है, तुम 6 महीने बाद फिर आना. तो फिर 6 महीने बाद आते हैं, आप उसको ठीक करते हैं, फोटो वो कहते हैं आप मुझसे पैसे लेते हैं, तो वो आपके पास आता नहीं है. अगर आप उसका जेनेटिक टेस्ट एक्सेप्ट हो गया
सर वो हमने भी पेपर प्रेजेंट किया है, लेकिन मालिक्यूल जेनेटिक जो है ना हमारे पास तो नहीं है, हम कराची से यहाँ में
हमारे पास भी नहीं है जी, हम
लेकिन आप जो
Sir,
है ये वक्त की नहीं ज़रूरत है ना, नहीं है, हर एक जगह जेनेटिक जो है ना अब लम्स के अंदर आ गई है
नहीं, इसको
Sir-
आप practically कब implement कर रहे हैं? For all the data. Because it will become only significant if you make it as a routine test for all the data. उसमें से हम filter कर सकते हैं ना कि in future these are the very candidates who need to be populated more frequently.
सर इसमें ये किया जा सकता है, डॉक्टर साहब ने जैसे राइटली सारा कुछ काम किया हुआ है, वाई शुडंट वी राइट अ लेटर टू द फेडरल गवर्नमेंट जो उनके पास इदारा है NIH, नेशनल इंस्टीट्यूट ऑफ हेल्थ, जिसके पास सब कुछ है, तो आई कैन फैसिलिटेट यू एंड हैव अ मीटिंग विद द सेक्रेटरी, तो मे बी दे कैन फंड यू।
व्हाट वी डूइंग एट द मोमेंट इज मैंने ओरिया फंड से बात की है, ये जो हमने स्टडी की है डायबिटिक्स के ऊपर,
जी
हम इसको रेप्लिकेट करना चाहते हैं पाकिस्तान में।
ठीक है।
एक सेंटर कराची में, एक लाहौर पंजाब में, आगे पीछे 5-6 हर जगह से 100 200 500 मरीज ले रहे। फिर हमारे पास अभी जो मेरे पास डेटा है वो 127 पेशेंट्स का है। इसके बाद हम उसको 2-4 हज़ार मरीजों को फिर करें तो देन वी गॉट अ सिग्निफिकेंट डेटा। मैंने ये स्टडी जब मैंने पब्लिश की है तो 127 पेशेंट के ऊपर है। जो सबसे बड़ी स्टडी है वो चाइना से आई थी, एंड वो हज़ारों के ऊपर करते हैं, वो लाखों के ऊपर करते हैं। मसला ये होता है कि हमारे पास पैसे नहीं होते।
No, sir, this is different. The previous one which you were mentioning, the primers, you know, they can be done with the help of government of Pakistan.
ठीक है,
हाँ जी, आप एक लेटर अगर लिखते हैं तो आई कैन फैसिलिटेट।
ठीक है, I'll get in touch with you.
Sir, with chairman's permission, since there are no presenters, so we have a good 10 minutes before. I would request the chairman to come. Sir,
the first paper was presented by Rabia Sharif, presented the morphological
Sir?
changes in the
sir, I would request the chairman to come over here and say a few words.
बात सुन रहे हैं
अच्छा वही से चलें ठीक है।
Thanks.
Okay.
So morphological changes in the endothelial cells, the wonderful paper, and by the changes of morphological changes, it definitely changes the functional changes also. According to the normal to morphological, little bit there were changes, functional changes according to morphology. Accident paper, the Mafusa always is present in the innovative paper, innovation. ऐसा सबके लिए जो है ना जरा वो हो जाता है कि हमने इस लाइन पे पहुंच जाए। आज की ज़रूरत है, the time for develop the molecular layer now in every university. Genetic study जो है माशाल्लाह आज जो है ना हमारे अशोक साहब बता रहे हैं कि हमारे एग्रीकल्चर लैब वो है यूनिवर्सिटी इसमें नौशा में उसमें भी आ गई है, और हमारे पास जो है लम्स के अंदर जेनेटिक जो है वो डेवलप हो गई है।
सबसे ज़्यादा आपके पास सिल में जी
नहीं जेनेटिक है लेकिन काम नहीं है। हमने आप डायबिटीज़ जो आप बात बताएं कि हमने ये 7 केस पे हमने स्टडी की थी, लेकिन कराची से मिलकर की थी। तो आज के वक्त की ज़रूरत है कि जेनेटिक जो है ना इनके लिए मॉलिक्यूलर लैब होनी चाहिए हर एक यूनिवर्सिटी के अंदर। और मुकीद साहब तो माशाल्लाह इतना काम किया है, हज़ारों केस किए हैं माशाल्लाह, एक्सीलेंट प्रेजेंटेशन। और ये सारे चाहते हैं कि ये ज़रा हमें भी जो है ना ज़रा इसका फेज मिल जाए ना। तो आप इतना फ्रीक्वेंट फर्स्ट क्लास है, कुछ चीज़ डेवलप हो जाती है ना फिर उनके लिए जो है ना हर चीज़ आसान होती है, लेकिन सारे चाहते हैं कि हमारे अंदर भी वो हो जाए, इनके ज़रा आप
सिंप्लीफाइड कर दिया।
सिंप्लीफाइड तो कर लिया है, लेकिन हैंड्स ऑन जो है ना जब ही होगा जब जो है ना आप वर्कशॉप और इस तरह जो है ना वो लोगों को
CPHP का पेपर उसमें एस्टेब्लिश हुआ हुआ पेपर।
थैंक्स सर।
Sir, now it's
wanted to comment right.
डॉक्टर साहब ने बताया ना कि एंडोथेलियल कम होते हैं, आपने कहा था हमारे ठीक है।
नहीं हमारे उस डेल्ट में ठीक है मॉर्फोलॉजिकल चेंजेस होती हैं उससे।
रीजन बताया पास का आपका जो पेशेंट का सेलेक्ट था ना उसकी एवरेज एज 18 शी ऑलरेडी सेट कि विद एज कम होता है, उनके भी जो स्टेज 1 और 2 में थे उसको ज़्यादा थे।
सही।
सो एक्चुअली दे आर बोथ द सेम थिंग्स। तो दूसरा डेल ये है कि व्हेन आई स्टार्टेड द डेल आई स्टार्टेड विद द कैटेट सेट safer and
And easier.
Sure. मैंने एक सीजर डिजाइन किए जो साइड की कटिंग के लिए होती है. It's so easy with that new scissor कि आप आंखें बंद करके काटे, हाई परफोरेट नहीं होती. और वो जो दूसरी वाली सीजर है जो हम पहले इस्तेमाल करते थे, आपको धड़ पे ही लगा रहता है कि अभी परफोरेट हुई, अभी परफोरेट हो गया.
वो आपने वो डिफाइन भी किया गाड़ी वो विल गेट इट इंशाल्लाह.
So,
इन लास्ट मैंने एक बात पे करना चाहते हैं आगे कॉर्निया वाले जितने भी हैं एलोकिस्ट तो कॉर्निया जो महफूज साहब से मिलकर बिकॉज सेकंड फेलोशिप के लिए दिस ऑन पाइपलाइन हो थोड़ा आप आकर पहुंचे हैं वहाँ पर सेकंड फेलोशिप कॉलेज फिजिशियन गोइंग टू स्टार्ट हो सेकंड फेलोशिप कॉर्निया लेकिन महफूज साहब के साथ थोड़ा काम करें थोड़ी डिफिशिएंसीज हैं उसमें जो है कंप्लीट
Everything is ready for the second fellowship except MCQs. So पहले 500 MCQs मांगते थे, अब जब तक 1000
अभी
MCQs
1000
वो एप्लीकेशन लेते ही नहीं. सब कुछ curriculum सब कुछ अप्रूव है, everything is approved. सिर्फ MCQs 1000 चाहिए और 1000 MCQs मेरे बस अकेले
दो
के बस
मिनट.
की बात नहीं है.
Sir.
काफी जगह लोगों को कहा है लेकिन कोई
sir, excuse me, sir, we are short of time. The next session is going to start in 5 minutes, so I would request the presenters, Dr. Mahfouz, sir, please to come over here and receive your sheet. Sir,
ये
आप आ जाए सर पहले.
सर मैं पिक्चर लूँ.
आज बाद से
जी सर.
Sir, Professor Mukeet sir से.
आ जाए सर सेंटर में आ जाए लेकिन ये हेड है सर इनके शिफा के और शिफा के पास 3 और 500
Thank you very much everybody.
काम ज़्यादा हो रहा है बनाओ यार मुकीम साहब जो है ना कह रहे हैं कि इंशाल्लाह 500 आपको
थोड़ा सा आगे आएंगे शेड आ रहा है
आगे इस तरह से
केराटोकॉनस होगा